Keratoconus to 2020 is possible, introducing a new refractive surgery algorithm to raise the bar on the subspecialty of refractive techniques. Keratoconus, if you stop getting scared by calling it keratoconus and just define it as a corneal condition, stable or unstable, with relatively thin cornea, high keratometry, with stigmatism associated with myopia or hyperopia. The exercise in futility is to grade keratoconus, score the topography, label the patient as complex, scare yourself and lower the patient expectations. That is absolutely unacceptable. All these patients, if you look at just leaving them dependent on contact lenses and delaying transplants, this should not be a goal. Delivering vision without glasses and contacts is the goal, and no harm in falling short of that goal in these cases and relying on residual contact lenses, but at least start and aim high. With that note, I want you to understand and remember these patients. These are all people with advanced keratoconus, complex keratoconus, and very, very amazingly challenging professions and personal lives, and doing very well at the highest level of their personal and professional life, even starting movements on their own to help other patients. And these are all patients who are seeing, who are referred and who travel from all over the world, given up on. But these are keratoconus patients. Remember their faces, please. Do not get scared of topographical abnormalities like you see. We've even corrected beyond 50 diopters of irregular stigmatisms. Follow the system that I'll be sharing with you today and change the lives of these patients. These are day one worldwide keratoconus patients from all over with different severities, and all, as you can see, day one, no pain, smiling with the vision that they have after all these years of share. So the new algorithm that I'm proposing, with having seen these kind of patients with every severity of keratoconus and complexities over the last 3 decades, and putting it together in a very simple concept of structural or visual. And that's how simple I want this to be. So if you see a patient whose best corrected vision is over 20/40, stigmatism, myopia, more than 400 pachymetry, stable, regular topography, no other pathology, you can actually do in these patients a visual surgery like LaZrPlastique and bring these patients, as you can even see, from 1.7 to 0 diopter. This is a firefighter who was taken to beyond 20/20 vision and got back to their life. And as you know, my Corneoplastique principles, you can also take these patients through scars, which are in cornea or on cornea, and bring them excellent vision. You can even use LaZrPlastique for patients who've had previous failed keratoconus surgery, like ICLs, or in this case, this patient who traveled to us after having ICL, multiple cross-linkings and surgeries, and we brought him straight to 20/20, as you can see, even the topographical changes. Now, if you take the same patient and it's more than 20/40 vision, best corrected myopic astigmatism, 400 packs, stable, regular topography, and no other pathology, you can also take these patients to ICL technology. The recently approved EVO and EVO toric ICLs are great benefits in these patients. Having had over 3 decades of experience with different kinds of ICL technologies from all over, we are very, very fortunate to now have the EVO ICL approval, which also have toric capability with the Centra EchoPort, and these patients can be extremely benefited, especially with high myopia with stable keratoconus. So you can see these cases, which are very easily done for any cataract refractive surgeon, to bring these patients to wonderful vision endpoints. Even complex ocular surface conditions can be first stabilized, like in this case with amniotic surgery, and then an ICL visual surgery used to bring them to excellent vision. Now, if you take that patient to over 20/40 vision, stigmatism, hyperopia, myopia, 400 pachymetry, stable, regular, and cataract, you can take these patients to cataract surgery with full confidence. Again, it's a visual technique because the patient is visual. You can again see here the pre and post-op topography looks nearly the same with 4 diopters, regular stigmatism, but you can use a toric lens implant to take these patients straight to excellent vision endpoints without contacts and glasses. And you can see this in all levels of keratoconus, even PMDs and other cases that you may have. Even patients with transplants that are done on keratoconus, they arrive to us with nystagmus, amblyopia, all these situations, but you can take these patients to excellent vision with stability in their eyes. Also notice the ambiance of surgery. Keep the LaZrPlastique principles alive, which is patients have no pain. They're having surgery under topical anesthesia. You can hear them, how comfortable they are. And these are complex patients. Even the newly released Vivity lenses can be used in these cases very confidently. If these patients are less than 20/60 vision, best corrected, stigmatism, hyperopia, myopia, over 250 microns pachymetry, stability is unstable, topographically irregular, ectasia, anterior scar, now you can do intact space techniques. Again, intracorneal implants could be intact, what we have here. You can use Kerr rings, you can use Ferrara rings. The concept's the same. Bring these irregular corneas, tame them down. You can see the stent diopters brought to 0.1 diopter, and then you can further do LaZrPlastique on top of that and bring these patients to excellent neutral visual endpoints. You can even stage these intact surgeries just structural, and then these patients become visual, and you can use confidently your evotoric ICLs and bring these patients to wonderful vision. Similarly, these patients with keratoconus stabilized structurally with the intact can undergo lens-based LaZrPlastique techniques and brought to excellent vision endpoints, as you can see here. A lot of our videos are available on YouTube for you, and for paucity of time, I'll keep continuing. You can even take surgical keratoconus cases like these with over 24 diopter astigmatism, stabilize and neutralize them with an intact ring to 1.4, going with a toric lens implant, sutureless LaZrPlastique, straight to wonderful vision endpoints. If the patients are over 20/40 vision, astigmatism, hyperopia, myopia, 300 packs and more, stable, regular, no other pathology, you can even do collagen cross-linking in these patients. And my concept of cross-linking always is, think about the cornea. Don't worry about epi on, epi off, how thin the cornea. All those are important esoteric discussions which you can absolutely discuss. My point being, do not cross-link the cornea in an abnormal situation without first fixing it. This is called the keratoscoliosis concept that I've defined to you previously. So these are patients, again, you meet all firefighters actually in one day who once were fixed, and then I've cross-linked them to excellent 20/20 endpoints. You can see patients who also can be brought from excellent vision endpoints, prepare them for cross-linking. Like this patient, you can see irregular astigmatism down to 0. Patients whose vision is less than 2100, irregular, less than 200, unstable, irregular, scar ectasia, you can do lamellar keratoplasty. You must be a master in corneal surgeries before you even do Lasik, smile, these techniques. Sutureless techniques that you must master, easily perform. Here is a patient who had traveled to us with 3 kinds of rings in the cornea, which we had to extrude with the level of blindness involved, and hand lamellar keratoplasty, you can see. Here is a patient with frozen anterior chamber following a failed ICL surgery that caused dense cataract, poorly dilating pupil with synechia, intact cross-linking PRK done, brought to straight LaZrPlastique visual. Patients with Holcomb C3R complications that we see can be corrected. Again, if you follow this algorithm, it doesn't matter what the level of complication is. You can fix it all. Caries complications can be corrected. Again, structurally, think about these patients as structural and visual, and you'll always succeed. Here's a patient who had 12 failed surgeries before he was sent over to us for keratoconus. And here we are reversing his ICL, leaving his intact in, leaving his cross-linking in, and then we went stage 2 cataract surgery and brought him straight to 20/20. So my request to all of you is, it's okay to diagnose keratoconus and debate about it, but someone needs to act. I want you to act, perform for these patients, and really believe in the fact that they can see. So give them the freedom, think outside the cone. This new algorithm will allow you to break down all my 28 techniques for keratoconus into structural and visual, as simple as that. Take them from structural to visual. If they're already visual, go straight to visual. Give them vision freedom. Thank you for your attention.